Hi friends, I am one of the member of the MRCOG OSCE preparation group. We are helping MRCOG Part 3 students regarding their OSCE preparation. We have a free group on the Telegram where we are helping the students for free. We have daily tasks and daily activities there. We also run some courses in between, and so those who are interested in individual studies and individual help, so we are helping the people there also. So today I want to discuss with you talk article regarding as the pattern of exam is changing day by day, and there is always some cases from the talk articles. Okay, this is my name. I am Dr. Fawzia Ayaz, and I am MCPS, MRCOG and MRCPI, and I am one of the member of the MRCOG OSCE preparation group, as I already told you. So we will present the summaries of some talks. This is the first summary which I am presenting, when other members are also preparing, and soon they will release their summaries also on the YouTube channel. These are free for all of you. So my first talk article presentation is about the management of the twin pregnancy with one dead twin. So what is this? What is the importance of this? First of all, when the twin pregnancy is diagnosed, it has got a psychological impact on the parents, because they are preparing themselves for the future of having two babies at the same time. So they are adjusting themselves to receive two babies rather than one. As if the one baby twin died inside the utero, so mother is still pregnant because the other baby is still alive. So, and many times if it is in early pregnancy, so it is, this loss is hidden from the other relatives or friends. Maybe they did not, in the early pregnancy, maybe they do not share with their family or the other relatives. So they are mostly concerned about the safety of the remaining twin. So there are two parts in the initial management, that there is a psychological impact. Sometimes they are not receiving support from the relatives and friends, as still they have not shared about the twin pregnancy. And this other thing is, they are very much concerned about the safety of the remaining twin. Vanishing twin is the term which is used in the when the one baby is lost in the first trimester. Actually, in 30% of the twin pregnancy, in first trimester, heartbeat is found in both twins. Later on, when one twin dies, it forms fetus papyracus. Death of the one twin occurring after 20 weeks defined as late loss. So vanishing twin is a term used for the early pregnancy loss of the one twin. Death of one twin is associated with the monochorionic placentation in 45% of the cases. So, as we know that it is more common in monochronic pregnancy. So people are thinking that maybe the twin transfusion syndrome is one of the cause, but still high drops or severe fetal growth restriction is not found in many cases. Birth weight discordance of more than 25% is found in only 11 to 12% of the cases. Congenital abnormalities are more common in twins, causing one fetal death in 25% of the cases. Some of the causes may lead to the APH. Preeclampsia also affect both babies, but fatal for one, like but other complications like filamentous cord insertion, it is found in 30% of the cases, and they may be associated with the vasoprevia in 50 to 60% of the cases. Usually, we have been observed that onset of the labor usually start within 3 weeks of intrauterine fetal death of one of the twin. Means Usually gestational age is around 26 weeks, but ranging between 23 to 32.5 weeks. Okay, so most common around 26 weeks of pregnancy. Monochronic pregnancy, the death of one twin leads a risk of cerebral damage in the co-twin about 25%, and the death of the second twin in further 25% of the cases. In contrast to the amniotic dichronic twin pregnancy, the remaining twin will be spared even after the death of the one twin. As a monochronic twins shared circulation, so thromboplastin releases from that twin can lead to the thrombotic episodes in monochronic twin pregnancy. So there is increased incidence of cerebral palsy in such twins. So one of the risks associated to the remaining twin is the thromboembolic event. When one twin heartbeat is stopped, severe hypotension in circulation can lead to the death of the remaining twin also. Different levels of cerebral damage are also seen because of the thrombotic effects like multicystic encephalomalacia, hydranencephaly, and eventually microcephaly. Early changes involves white matter and appears as leukomalacia. In dichronic pregnancy, management depends on the gestational age and underlying known pathology like preeclampsia. So most common cause is preeclampsia. In such cases, delivery is requested by parents beyond 34 weeks. Steroids should be offered if pregnancy is less than 36 weeks. Route of delivery depends on the presentation of the live twin. If breech, cesarean section is indicated. If that twin is leading, cesarean section can be offered, but if vaginal delivery is contemplated, it is needed to carefully monitor the live twin. In die-die twins, if one twin dies before 34 weeks of delivery, the delivery can be delayed up to the fetal maturity. But careful monitoring of the live fetus with CTG, Doppler, and ultrasound should be done, including amniotic fluid index. Spontaneous labor is expected within few weeks, but careful monitoring of maternal clotting factors is needed, which usually range after 4 weeks of intrauterine fetal death. Fibrinogen, PT, APTT, and maternal platelets to be measured weekly. Monochronic pregnancy. The problem in the monochronic pregnancy is different from the diamniotic dichronic pregnancy. As mentioned above, the death of the one twin is occur in about 50% of the cases, leads rapidly to the death and damage of the remaining twin fetus. The main damage, as I already told you, the survivor's brain, and this may take up to 5 weeks to become apparent. The appearance of porencephaly on ultrasound indicates that the brain has been severely damaged, and the outcome for the baby will be poor. Under these circumstances, the couple may wish to consider feticide and delivery of the baby, but understandably, this whole process can be immediately upsetting. Thus, for the monochronic pregnancy, the best plan is to delay the delivery of the live fetus for as long as possible so that an intracranial features have time to become apparent. The presence of these changes should be determined by performing a weekly ultrasound examination of the fetal brain. The use of MRI should certainly be considered, but the value of this modality has yet to be established in these circumstances. In addition to evaluating the fetal condition, the importance of monitoring the maternal clotting screen should be remembered. Other interventions have been tried, including rescue transfusions, but they may not influence the eventual outcome. However, evidence of profound anemia in the survivor when blood sampling was undertaken within 24 hours of the death of the co-twin did appear to have prognostic value, the eventual outcome in this group being usually poor. Conversely, the absence of anemia appeared to be associated with a good outcome. So the presence of a pregnancy complication such as preeclampsia is important, not just from the point of view of the mother but also of the remaining fetus. If it is felt that the condition has led to the death of the one fetus, then it is reasonable to assume that the remaining fetus is also at risk and delivery should be expedited. This probably applies to the both monochronic and dichronic pregnancies. This is the chart which shows the summary how we have to manage. So if one twin die, and we have to re-evaluate remaining twin and underlying etiology. So etiology is important. If there is preeclampsia, we have to deliver the baby. If it is a monochronic twin, we have to sort out there is maternal causes. If maternal causes like preeclampsia is there or antepartum hemorrhages, we have to deliver. If no obvious cause for the intrauterine death of the remaining fetus, of the one fetus in the monochronic twin, so we have to prolong the pregnancy. Weekly scans to evaluate the fetal brain and signs of brain damage. We have to discuss the fetus sites and brain apparently normal, consider MRI. Normal, continue the pregnancy till the fetal maturity. If it is dry chronic maternal causes, consider delivery. No obvious cause, continue pregnancy and monitor growth till the fetal maturity. This is the flow chart for the management of a dead twin in both monochorionic and the dichronic. I think it is clear. Then what is the outcome? Generally, the outcome when one pair of twin dies is not good. In one study, the intrauterine death of one of the twins resulted in 70% being admitted to the special care units, compared with 5.6% of the twins from the pregnancy in which both babies were born alive. So this is a big difference. A review comprising 66 monochronic and 77 dichronic pregnancy indicated that in the former, means monochronic, there were 6 stillbirths, 2 neonatal deaths, and 7 cases of brain damage and cerebral palsy. 3 cases had been damaged as a result of prematurity, making a total adverse outcome of 27%. In contrast, the dark chronic pregnancy, out of 77, there is stillbirth of only 1 stillbirth, 4 neonatal deaths, and 1 case of brain damage due to prematurity. A total adverse outcome is 7.8%. So there is a big difference between 27.2 to 7.8. In Australian series, there was a 15-fold increase in cerebral palsy in twin pregnancy in which one died, compared with pregnancy where both were alive. In large cohort study in the UK of the twins in which one twin died, cerebral palsy in the survivors had an incidence of 106 in 1,000 in like sex twins, compared with 29 in 1,000 when the sex between the twins was different. So what we have conclusion: the intrauterine death of one pair of twins generates enormous emotional pressure for the parents. From the obstetrician perspective, the important issues are chorionicity, gestational age, and the presence of any underlying disorder such as preeclampsia. So what we have to keep in mind from the parent side is emotional pressure, and from the obstetrician point of view, there are chorionicity, gestational age, and the presence of any underlying disorders such as preeclampsia. The danger is greatest for monochronic pregnancy when the risk of death and damage in the remaining two is around 50%. In monochronic pregnancy, delivery should be delayed for as long as possible to see if evidence of structural brain damage is there. So thank you very much. I think this talk article summary will help you in understanding how you will manage when there is death of one twin in monochronic pregnancy and the dichronic pregnancy. If you have any questions, you can join our this MRCOG Oscar profession group on a Telegram channel, and we will be happy to help you in your OSCE profession. Thank you very much.